I please call upon Dr. Subudhi
Yeah.
to please start the session.
Thank you.
Over to you,
Thank
Doctor.
you. Thank you. So, good afternoon. Welcome you all to this grand IC. The topic is, as you know, it's a diabetic retinopathy, epidemiology, and telescreening in the post-COVID era. So we are passing through a very bad period. You know, the COVID since last 2 years, and diabetic screening has been back-footed, and a lot of diabetic retinopathy cases has come up. So we have a very hard task ahead. So we have to find out a way. How do we screen them? So can telescreening, teleophthalmology be support us for this huge amount of diabetes screening? So today I'm really fortunate that to have with us our guest, international speaker, Dr. Aba Hussain, and she's from Bangladesh. Along with her, our great boss, Dr. S. Natarajan, Dr. Kim Ramaswamy, Dr. Ajit Babu Maji, Dr. Rajiv Raman, Dr. Sabyasachi Patnaik will be doing the discussion for another 1 hour. So with these few words, I welcome you all to this today's. Just I will introduce Madam. So Professor Aba Hussain, everybody knows, sir. Always any AIOC conference is with us. So anywhere, whenever there is a conference in Delhi, she is with us. So very loving face, and many times I met her very much. She is at present the chief consultant at OSB Eye Hospital, Dhaka. Her significant contribution towards the preventive blindness in Bangladesh and the Asia Pacific region are widely recognized. She has vast experience and expertise in the fields of cataract, glaucoma, vitreoretina, and ocular trauma. She has long 40 years of experience. She worked at the National Institute of Ophthalmology for 17 years. And she is the president-elect of Asia Pacific Academy of Ophthalmology. And she is also the chairperson of the APAO Women in Ophthalmology, a great honor for her and for us also. So this year, the ophthalmologist nominated in the power list of 100 women ophthalmologists of the world. She's really a powerful shot with us. And she was the past president of SARC Academy of Ophthalmology, Ophthalmology Society of Bangladesh, and founding president of Bangladesh Community Ophthalmology Society. She's got a lot of experience in the community work. So I welcome you, madam, to speak us about your experience in the past few years about the community work, and also how to curb, how to avoid this preventable diabetic blindness. So with this, I request Professor Aba Hussain to give her lecture.
And actually, she is the first women president of Asia Pacific Academy of Ophthalmology we are going to have. And I'm glad we have our neighbor country to lead Asia Pacific after China now. Dr. Ningli Wang is the current president, and she will be taking over as the president. So
thank you so very much, Dr. Subudhi, Dr. Natarajan, and Dr. Rajiv, and all other respectable persons. Good afternoon. Let me share my screen. Let us work together for preventing avoidable blindness. See how happy is the grandfather after doing the cataract surgery. Am I clear?
Yeah,
Yes,
you are very clear, very clear.
And also the granddaughter after being the cataract surgery. So globally, 43.3 million people are blind, of them 55% are female. and 295 million people with moderate to severe visual impairment. And among these impairment, the people live in low and middle income countries. There is a prediction that 61 million people will be blind by 2050. What about the Asian region? As we all belong this region, so the highest blindness in South Asia, that is 11.90 million, and the lowest one is the high income Asia Pacific, that is 0.53 million, and next is the East Asia, that is 9.09 million, and lowest one is the Central Asia, 3.01 million, and our part, that is Southeast Asia, 5.95 million. So what about the Bangladesh situation? Let me tell about the prevalence of blindness. That is, it was 1.53% in 2000, and after 2000 there is a new blindness survey in 2020, and the prevalence has come down to 0.77%, and number of blind is 650,000, and it has come down now 527,000, and the backlog of cataract 517,400 and 389,614 now. So the major cause of blindness, that is untreated cataract, 70%, and the other 30% are all other, DR, glaucoma, and ARMD all. So to prevent or to reduce the cataract backlog, there are some strategies has taken to provide high quality, low cost cataract surgery to eliminate the backlog by increasing the cataract surgery rate, improve quality and outcome of surgery, provide accessible, affordable services to the hard to reach area, and to raise the public awareness by early detection and referral of cataract. By strengthening existing facilities at different level and also establishing new facilities at the different level by developing the infrastructure. At present in Bangladesh, 90 community vision center has established, and the aim is to develop 600 community vision center by the year 2030. One community vision center cover 300,000 population. Utilization of modern technology by ensuring the supply of modern eye equipment to all eye care facilities. These are the community vision center and the base hospital. The community vision center situated around 50 kilometers around the base hospital. And from there, the surgical cases are all referred to the base hospital, and the base hospital have enough equipment to do, and also the human resource to do all these surgeries. This is one of the base hospital in the district Gopalganj, that is Sheikh Fazilatunisa Mujib Eye Hospital and Training Institute. So how we can develop the human resource? By developing the subspecialty and also the subspecialty ophthalmologists for the training to send abroad, and also in the country training should be given. And also the MLOP and the eye care worker should also develop. Advocacy meeting with policy or decision maker and the professional bodies and community leaders should be done periodically. Beside that, billboard, poster, leaflet, TV spot, and radio program for awareness development program. Coordination mechanism between geo, NGO, and private sector should be strengthened. Expansion of maximum collaboration in service delivery through different agencies, and private sector should encourage to take more responsibilities in providing low-cost services. Demand-side financing is a special program of our government to provide financial support for the marginalized group of people for doing cataract surgery. And this support covered the transport, the food, and the subsidy for day loss. 10,264 cataract surgery was done under this scheme from 2017 to 2019. The coverage is very low due to the pandemic situation in 2020. Monitoring tool should be developed, ensure feedback to the policymaker from evaluation, and also the periodic review. Beside all these strategies, there are, of course, so many challenges. Number one challenge is that inequitable and mismatched human resource, that is 80% ophthalmologists live in urban area and 80% patient lives in rural area. Retaining skilled eye care provider at the rural level, maintenance of eye care equipment, under utilization of the Department of Ophthalmology of the academic institute, increasing cataract surgical rate and cataract surgical coverage, and more engagement and coordination with eye NGO in eye care. There are also social and cultural barriers for not receiving eye care, and gender disparities in receiving the eye care is another challenge. Prioritizing eye care and positioning eye health within the broader health agenda. Integrating eye health into poverty reduction strategies, policies, and initiatives. And institutionalizing MLOP cadre and evidence-based planning. So let us fight together. As there is substantial variation in the causes of avoidable blindness between countries of our region. So need to develop regional strategy and guideline to build strong cooperation to promote shared learning and exchange of technology. Exchanging public health experience in preventing blindness and developing opportunities for competency-based training, fostering service development network, knowledge sharing for improving quality, productivity, equity, and access to cataract services. There are valid epidemiological data is very crucial in designing country-specific strategies for prevention of blindness. So research should perform to address challenges of eye health, including sustainable financing. Find out the gaps for each challenge through high quality evidence generation and advocate for the integration of eye health with continued health system strengthening process. To conclude, let us set up country-specific regional priorities, develop a common guideline for our region, strengthen eye health services, reduce social impact by increasing effective rehabilitation, and guide to investing more for preventing blindness. I like to believe that the days are not far when we will be able to eradicate blindness from the face of our region. With your support and cooperation, we would like to take our dream one step close to that day. With all, thank you so very much.
Thank you, madam, for your elaborate description of what strategy has to be followed in this region. May I request Professor Natarajan to give his comments to the madam's lecture? Dr. Natarajan sir. Dr. Ajit Babu, can you please say what?
Nati has come.
Yeah, no, Ajit will tell.
Dr. Natarajan, sir. Dr. Natarajan, your
Yeah.
comments, please. Your comments.
No, Nati, if you are telling, it's okay. Otherwise, I will tell. Don't
No,
worry.
you tell, Ajit.
Yeah. As Professor Awa indicated that we both are developing countries. We are not developed countries, and we have a common epidemiological problems, especially in terms of ophthalmic this thing. And each country need to identify their priority. See, we have limited resources to invest on also. It is not that we can completely erase all the blindness, but how best we can utilize the resources. That's what we need to focus. And for that, a good strategical planning is very, very essential. And she has rightly pointed out that. And we all need to prioritize the number one priority of avoidable blindness, how to tackle, number two and number three, like that. And then whatever resources we can raise, either from the governmental sector or private sector, that need to be utilized properly. I think that is the gist of her presentation. And she has pointed out very nicely. Thank you.
Thank you, sir. Thank you, Dr. Ajit
Thank you
Babu,
so
for your nice comments. So let us pray. Give our thanks to Professor Aba Hussain, madam. Thank you very much for joining with us. So we'll be
Subhuti,
seeing you
only
very
one
often.
small point I want to add is, in addition to
Yes.
what Ajit said, I think the Vision 2020 was formed in 80s with that idea where everybody right to sight and everybody will have right eye and left eye equal. Similarly, as Dr. Ajit said, even though we know we cannot remove the blindness, and even Dr. Venkateswamy has mentioned to remove the like a needless blindness, I think we have to aim for that. It is like how Bhagavad Gita says, you aim high so that you land somewhere, so that you remove blindness to the maximum. And that's why our AOS have made a program, Diabetic Blind Free India 2025.
Yes.
But we know that at least we can screen everybody. That will be a great achievement. At least in that angle, we can increase the awareness. And as Ajit said,
Yeah.
we have to
Yes,
increase
yes, Nati, you said the right thing. Nati, you said the right thing. You aim for the sky and you reach hilltops.
Thank you, ma'am. Thank you.
Thank you
Dr.
so very
Natarajan.
much. Thank you for your
Thank you, everybody. Ma'am, we will be seeing you very
comments.
often in this region. So, thank
Can you
Now,
allow me to go and join to?
ma'am, please carry on to join
Thank
the
you
other
so
program.
much.
So
Thank
now
you.
I request Dr. NSD Raju sir to give your introduction to this course of this diabetes retinopathy, epidemiology and telescreening in the post-COVID era. So Dr. NSD Raju sir.
Thank you, Dr. Subhuti. I must express my gratitude to you for permitting me to be a faculty of this very important instruction course, that of the epidemiology of diabetic retinopathy and telescreening post-COVID. Diabetes, as we all know, is a major problem in most of the developing countries, and it's especially so in a country like India, where I think, I'm sorry, I don't have a slide presentation. I have a slide presentation, but my PC has broken down. Not into pieces, but it doesn't work now. So I'll go. Okay, we know that the mind-boggling figures of the diabetics in India, that is supposed to be some 80 million people in India are supposed to be diabetic. And if you look at the prevalence and epidemiology of the diabetic retinopathy in this group, you find that about 17 to 18% of them have diabetic retinopathy. So it's a major health issue and a great concern, and a major concern, a great, I think it's a major health issue and a major concern for health authorities and the government alike. So these studies, I think the epidemiological studies have been done in India at different places like Chennai, then in Hyderabad, AIMS, and we find that almost the same result have been produced in all these studies. And when you compare that to the prevalence of this diabetic retinopathy in Western countries, the most important study, I think, Nati might recollect, it is the Wisconsin study. So there they found that eventually about 80% of all diabetics are likely to develop the diabetic retinopathy in their lives. So also in other European and Western countries, the incidence of, the prevalence of diabetic retinopathy has been estimated a little higher. It may be some 25 to 30%, but some reason or other, which we are not very clear, our incidence is only about 17%. So we in India have been trying best to fight this avoidable blindness from diabetic retinopathy. The All India Ophthalmological Society and the Indian Medical Association have joined, a conjoint program has been devised which aims at increasing the awareness and also increasing to screen all the diabetics for diabetic retinopathy. But unfortunately, that program was going on very well. Then came like a bolt from the blue, the pandemic, which struck us without any notice. And then we were suddenly taken aback and could not do much of a work in a couple of months afterwards. But we somehow got back to the system, and we found that we will have to do some drastic changes in our approach to the problem, and that we have done. And I think Dr. Natti and other speakers are going to elaborate on how, on a digital platform, how we can, in this post-COVID era, we'll have to strengthen our infrastructure and make the digital platform very strong, and then continue our efforts so that we could spread the message. We can create and spread the message across the country, and also increase the number of diabetic retinopathy screening. So let us see what are these newer trends. So teleophthalmology, I think Kim is there. He is going to elaborate on that. The most important point is that in the remote rural regions, you can send a trained technician or a non-technician with a mid-range camera, or if it is a trained person, he can go with a slit lamp and take a dilated view. Otherwise, non-mid-range camera.
You are muted, sir.
Yeah, she's muted. Yeah.
I didn't do that. Someone else did.
Yeah, universe is there behind you, so anything is possible.
Somebody is behind me. It seems.
Yes, universe is there. Whole universe is there.
Okay, then the next thing is about the incorporation of these newer techniques and technology pertaining to the artificial intelligence. Most of us know about that. We can use the artificial intelligence software. You are going to hear a lot of it from Rajiv Raman. And then along with that, if you use the non-mid-range camera and using an AI software, you can diagnose not only diagnose, you can classify the retinopathy. So all the retinopathy, the sensitivity and the specificity is about 95% with this technique. And the sight-threatening DR, they call it as STDR, they have 99% sensitivity and 80%. And referable, what is it? Somebody time up. Okay, I have only one more point to say. And the other thing is to use the fundus camera. Instead of the fundus camera, we can use our smartphone. It also takes a similar picture which is comparable to the fundus camera. So we have all these new gadgets with us, and we'll go ahead and continue our efforts. And I'm sure that in the long run, we will succeed in all our attempts to fight against this avoidable blindness. Thank you.
Thank you, sir. Thank you, sir, for a nice introductory talk on the topic to be discussed. Whatever you talked, all the components now will be discussed by all our speakers here. So now may I request Dr. Sabyasachi Patnaik to throw some light on the epidemiology and impact of diabetic retinopathy in our country. So it's over to Dr. Sabyasachi Patnaik.
Thank you, sir. Thank you for giving me a scope to speak in presence of luminaries like Dr. Natarajan, Dr. Ajit Babu Maji, Dr. NSD Raju, who are veterans in the field of not only clinical management of diabetic retinopathy, also its public health approach, how it should be done in the country. So coming to the epidemiology, as has already been described a little bit about Dr. Raju, diabetes is now a major public health problem in India because day by day it is increasing. And today, as per 2019 estimation by International Diabetes Federation, around 77 million people in India have diabetes. And this is going to increase to 130 million by 2045. So prevalence is high in states like Tamil Nadu, Kerala, and also in Delhi, but low in Rajasthan, Bihar, Himachal Pradesh, and northeastern states. The prevalence is higher in males in comparison to females, and it increases with age in male and women. So for every 100 overweight Indians aged 20 years and above, we have 38 diabetics in comparison to global average of 19. So as the Indians are gaining weight, the chances of the prevalence of diabetes is also increasing. Coming to the prevalence of retinopathy in India, various studies, it varies from 17.6 to 28.2%. But recent national diabetic retinopathy survey by NPCB and RP Center, they found out to be 16.9%. So calculating that to the population of India, we have around 13 million people with retinopathy in India, and out of them 3 to 4.5 million are having vision-threatening diabetic retinopathy. So each diabetic retinopathy has high psychological impact on the individual, has a tremendous social impact in his family, and also in the community or in the state he belongs to. And ultimately, there is a huge economic burden to the country at large. So, but good news with blindness due to diabetic retinopathy is there is a declining trend in high-income countries like UK and US. It is mainly because of their concerted public health effort, increased awareness among the public, regional and national level diabetic retinopathy screening program that has been conducted in those countries, and there is availability of improved therapies and services for treatment of diabetic retinopathy. But this is unlikely to be reflected in India in near future because we don't have a proper planning how to address this issue. There are lack of resources and limited access to quality and affordable eye care services.
Some problem with the audio, I don't know. Is it a general problem or something? We can ask our host to check it up.
So what should be the strategies for India? We have to have a collaboration between physician and diabetologist and ophthalmologist. And prevention of control of risk factors are very important to prevent retinopathy. We have to build a national registry of diabetics so that we can properly follow them up and see that they are being properly examined and screened for retinopathy. There has to be establishment of nationwide diabetic retinopathy screening and research network. Screening of all diabetics has to be done to detect vision-threatening retinopathy. Non-mediatic fundus camera with smartphone technology and teleophthalmology solutions at primary healthcare institutions will help us in a great deal, particularly in COVID time where we don't want people to move around or to congregate at single place. So this teleophthalmology or telescreening of retinopathy of the diabetics is going to be the solution for future. So we have to have an efficient referral system for all diagnosed cases to secondary and tertiary level for further diagnosis and treatment. So Thank you very much. And I think these are the strategies that we have to adopt somehow at the national level and to be implemented at local and regional level to address this problem. Thank you very much. Thank you, sir. Sir, you are muted, sir.
Buddhi, you are muted. Dr. unmute.
Yeah, sorry. So can you discuss on this topic, whatever Dr. Patnaik has said? So increasing the infrastructure, then utilizing this, causing a national registry. And of course, our subsequent speakers will tell us about forming a national registry and how to screen the people. So may I invite Dr. Ajit Babu and Dr. Natarajan to say a few words on this?
Again, Ajit Babu always precedes me. Except
Smart fellow.
It would be better to have the.
During my presentation, I am proposing a district registry because unless you go with the smaller units, it's very, very difficult. And national will never going to happen unless each district is
Yes.
fully addressed. And it is easy to address. And while addressing a district registry, if you are successful, go to the next registry or next district, and like that you can cover most of the districts.
Yes, sir. The purpose is we have to have a national registry, but the data is to be
100%.
collected. Data has to be collected from district level.
Yeah, district level.
So unless there is a national or central government involvement in this thing, this is not going.
The ultimate goal is national.
Yes.
Start with
Yes.
district.
Yes. Planning at national level and implementation at local and district level.
no, Sabyasachi, that is why Echo India is doing on tuberculosis.
Yes.
And I think I forgot mental health, tuberculosis, and something. So when they are working with the national, I think they have to work on this. I don't know how Dr. Sandeep, we have to, and Kim is here. Maybe Kim will address this during his talk. Kim? No, I think Echo India has that networking for that national plan. Because government directly has a NCPB, not for DR. NCPB is there, National Control for Prevention of Blindness. And that's why I had a meeting with Dr. Nam, Dr. Mr. Tulsi, and Kim, which has to be incorporated with AOS and TOSI. So the AOS we have suggested is because Dr. Nam also suggested what he's doing in the Theni district. Kim mentioned about Tirunelveli experience, how difficult it is to work with the private-public partnership in Tirunelveli Medical College. And Tulsi said, what is the lesson we learned from cataract blindness? Correct, Kim?
Natti, there's one point I would like to point out. That is with this, there is a National Society for the Prevention of Blindness in India.
I'm the president.
You are, yeah. So I am carrying coal to the Newcastle. Please excuse me. So I think I have also some liaison with them. So what I thought was, if you could have some liaison with these bodies, like this National Prevention Program and all those things, the NGOs and all, and make it a very comprehensive one. As Babu rightly pointed out, we cannot have a national program. Rome is not built in a day. You need to work from the grassroots. Like Subudhi told us, you better go to each state and have the state activities straightened and in full form. Then you get a full-fledged national program. Thank you, Subudhi, for pointing out that very important point.
Thank you very much.
Dr. Subudhi, sir. Can I suggest that we have we have the discussions because all of us are talking about the same topic. We will have a discussion at the end of the.
Okay.
Yeah, I think that'll be better. Yeah.
Okay, we'll be discussed later. Okay, now we move over. So since last 2 years, we are toiling with this COVID, and during this COVID period, a lot of screening has been stopped, and we're not able to go to the people to screen the diabetes patients. So let us see what are the challenges during and following this post-COVID era from Dr. S. Natarajan. So may I request Dr. Natarajan to give his lecture?
Okay. So I will share my screen.
Yes, sir.
So the talk given to me is the challenges during and post COVID 2019, and we all have spoken about this diabetes and its complication threaten global health. And in India, we have this diabetic retinopathy, the leading and potentially preventable cause of visual impairment and blindness. And our entire group here in this IC is doing that. And caring for diabetic patients in the COVID-19 era is, according to me, a challenge, because people with comorbidities, now with this black fungus or the mucormycosis and the candida, people are afraid to come. So retina specialists face the unique challenge of caring for the patients that are at high risk for diabetic blindness during the era of COVID-19. And pandemic-related concerns are affecting our diabetic patients' diet and lifestyle, and even their ability to access medication and routine medical care. This is actually during the total lockdown, which was there last year. But partial lockdown, many things have been cleared, but still people don't want to come. And the COVID-19 lockdown is threatening the sight of thousands of people, as eye clinics have reported more than 70% reduction in the new referrals and a high rate of missed appointments. And this has been published by the UCL by Tufail Adnan in a paper saying a few million are not able to take appointments for diabetic because every clinic was closed last year. And the COVID-19 pandemic and associated safety measures have prompted a change in the provision and delivery of eye health services, which every hospital did that. And a large number of vision programs have been temporarily suspended, including mobile eye screening exercises and non-emergency surgeries in an attempt to reduce the risk of exposure to COVID-19 for both patients and health workers. I think it's opened up from October. Several concerns have been raised regarding proximity of eye care professionals to patients during eye examination. The pandemic surely has implications both of eye health and eye care professionals. And there was a session of COVID-19 martyr session about 11 to 12:30 by Partha and the Governing Council. I think around 160 ophthalmologists who are members of AIOS have died in the COVID. It's really sad to see so many ophthalmologists have died. And consideration for serving this vulnerable population during an evolving crisis, communicating to patients the precautions your practice has taken to ensure that safety can be a critical component in easing patients' fear, providing guidelines to referring doctors, greater reliance on imaging technology, and communicating with patients. Communicating to patients all the precautions they have taken to ensure their safety has been a critical component to ease patients' fears. Mass communication, reach out by phone to patients who are scheduled for treatments to confirm appointments and explain the new protocols. And this was last year where I learned from, I think one of the earliest was Arvinda Hospital. I heard Shushusha, Shantana did this videos in the last year. So, and we had to do all this. Even now we do, but we don't have to follow the same extra precaution which we were doing during the total lockdown. We did close the hospital even for a day, and where there was skeleton staff, doctors available, and this was the time when it was a total lockdown. And I saw videos from Arvind, and just cleaning of instruments and the staff wearing the plastic shield to examine patients is even now carrying on. And during the last year, the only emergencies were taken. And tele-ophthalmology we tried, but somehow it didn't work the way I wanted. And this is the precautions taken. And even today, my anesthetist says better to wear the PPE and operate. So I have a PPE, and then over that we wear the sterile gowning. And then I know I wear 3D, I do 3D surgery, so I have the 3D glasses. Even today I'm doing this, today morning also I was asking the anesthetist, it is really required to do all this, and maybe during the end of the talk we can find out whether it's really required to do OT procedure like this. Even though as a retina surgeon, we are spending a lot of time. Anesthetist says better to do that because they are in the operating room and we are close to the patient. So I think all this I'm still doing it because of the COVID, and that this is what. to do all this to tell the patients that you are following and coordinating with referring physicians, encourage referring physicians to capture and share with us the ultrasound wide images of things about whom they are concerned. Reviewing the ultra-wide field images help us determine how urgently this patient needs to be seen, or if they can instead be managed by the referring doctor. So we are doing through WhatsApp and Zoom
linkage
and improving clinic efficiency. And also this is what we are trying, and we are doing that in the last, even during the partial lockdown, we have started. It's slow. The Bombay Municipal Corporation clinics are open, so we are doing the screening awareness, assembly
and
capturing of images and uploading, diagnosis and real-time advice by the ophthalmologist or using the AI or the offline AI, and then innovative. This is a diabetic retinopathy care model where we have the pioneers of Rajiv Raman, Kim Sabyasachi, and Dr. Subudhi doing. Dr. Raju and Biju Raju also have done a lot of like this handheld device and also portable fundus camera. This is a remedy. I don't have any financial interest. And this is again to show fundus on phone and size. We carry this instrument in the motorbike and go all over, either the forest camera or the Remedio. And then the challenges post-COVID, the COVID-19 related lockdown was related to the postponement in patient care, which resulted in significantly worse visual acuity outcomes in patients with diabetic retinopathy. Somehow, because one eye is all right, they come so late, even today, every day they come, one eye has vitreous hemorrhage, and the other eye is having pre-proliferative diabetic retinopathy, they come, ask them, why didn't come? So because of COVID. And consequences of lapse in anti-VEGF therapy during COVID-19. Despite the efficacy of anti-VEGF treatment in resolving gross anatomical derangements, the damage done to the retina on a cellular level and the deterioration of visual acuity after lapse may in many instances be irreversible. Very difficult to convince the patient, because when you send videos and call, they think that you are doing marketing and you are trying to call patients to make money. So sometimes I tell the patient, it's up to you. My staff gets a little disappointed saying, they tell me, don't call. I said, all right, make a note and enter in the computer. And I said, leave it. Information regarding visual loss that can occur with lapses should better be counseled to patients on the consequences of loss to follow. Maybe all of us can compile the data and maybe publish and also publish it in the newspapers as a general saying that if you neglect eye care, particularly the diabetic, you have a problem. The pandemic is not just a challenge for health system, it is also a socioeconomic burden, because the gap in eye care impacts everything from education and personal mobility to road safety and prospects for employment. This is why our current reality should not inhibit our ability to generate a new paradigm for infrastructure, distribution of eye care providers, and eye care setting. There is indeed so much to speculate as to what lies ahead. What is the future of eye health as the world adapts to the new pandemic landscape? And what will we learn from the pandemic and its lockdown? Only time will tell if we acted wisely. What we do know, however, is that everyone deserves an equal right to sight, no matter where they live. Hence, I suggest when you are doing that care, please make sure you protect yourself. So I follow this SMSV, that is to say S for sanitizing, M for wearing mask, and S for physical distancing or social distancing, and V for vaccinated. And after all that, you should follow the precaution. And I think we have to remain safe, because to look after ourselves, our family. So one is you have to have a holistic approach, be happy, and worries are there for everybody. So you're not alone. And make sure you call a friend. That's what I said in that morning session, and also on the first day in the leadership, that when you are, everybody will have some problem. So I have my own friends to talk about the hospital, the financial problem, the loan, paying the staff, people taking leave, or somebody, I think we had 50% of staff had a COVID and come back, fortunately, and somebody has a problem in the family. So I think we have to address everything, and a holistic approach is required for ourselves, for our family, and for the staff and staff family. I think that will help to combat this epidemic and come out safe. Because COVID will end one day, but it's not ending shortly. It may be there for a year or maybe a year at least. And there is an American Academy opened up. I don't know whether any of us can travel, even though I have planned to travel, but I don't want to take any risk just for the sake of traveling. I know people ask me, are you depressed? I said, no, I'm happy. Now I know how to utilize my time. So one thing I do is I sleep at 10, try and get up at 5, do the morning exercise, then meditation, do OPD, then evenings webinar. On this 5 days, I decided be at home and be with all of you in all India.
Thank you. Thank you, sir. Thank you, Dr. Natarajan. I think we'll move further, and I will invite Dr. Rajiv Raman to give his lecture on AI in DR screening. Dr. Rajiv. Yes, Dr. Rajiv. Yes, please.
Started with a thank you slide. I remember Baburaj.
That was the last talk. Last talk of yeah.
Please.
Baburajan said, I don't know whether the time is up, so I want to start with this thank you slide.
No, it's
Thank
Rajiv
you,
Raman's
sir.
way of presenting.
Thank you, sir. Thank you, sir. So next couple of minutes, I'll be sharing some thoughts.
So we want to
AI.
congratulate Rajiv Raman for the Peace Everyday oration.
Thank you, sir. Thank you, sir. All your blessings. So next couple of minutes, I'll be sharing my thoughts on AI for diabetic retinopathy screening. So what do the diabetic retinopathy screening guidelines say about using AI? And very recently, 2020, American Diabetic Association has included AI for DR screening as one of the things in their guidelines. And they suggest that one can use any AI system which can detect more than mild NPDR and DME authorized by FDA as an alternative to a traditional screening approach. However, they went ahead saying that the result of these examinations should be documented and transmitted to a healthcare professional, meaning they want to complete the loop. When AI should not be used. So patients who have known retinopathy, they should directly be seen by an ophthalmologist. Or if there is a prior retinopathy treatment history, again, AI should not be used. Or if a patient has a symptom of visual impairment, again, AI is not something which should be used in that. In these patients, they should be seen in person by an ophthalmologist. What do the AIOS guidelines say? So this was a work which we had done, and the consensus was that because we don't have any legal framework for using AI today, it's empirical that if there is diabetic retinopathy detected by AI, they should be seen by an ophthalmologist. And a subset of those who are not detected as DR, they are normals, at least 10% of them, these images should be graded by ophthalmologists too. However, these things will change as the algorithms become more mature. Are these algorithms accurate? So this was our initial work in 2016, where this was one of the first study which showed that deep learning can be used to detect diabetic retinopathy. And happy to share that this article was judged as the top 10 article of the decade last year by JAMA. And then there have been many studies which have looked into development and validation of an algorithm. The good thing is accuracies of most of them is reasonably good. That becomes more confusing, that how you select an AI algorithm in your clinical care or when you want to do it for your screening. One must look into the original study which was used for validation, how many number of images were used for a training set. In our JAMA study, we had found a cutoff of 60,000 images, that after that, the AI training doesn't improve much. So if you have less number of images, you should think about how good the algorithm would be. How the ground truth was ascertained is very important because algorithm learns from what has been told to it. There are a variety of ways the grading or the ground truth can be ascertained. It can be a single ophthalmologist, a retina specialist, can be multiple grading, education, like two people telling and a third educating it. You must look at how nicely the ground truth has been ascertained, because that will give how robust the AI algorithm is. Whether the algorithm was trained on a mydriatic image or a non-mydriatic image. Dr. Natarajan's work on a non-mydriatic image, that means that will work pretty good. Those algorithms will work or if you use a non-mydriatic camera. I think that is again an important thing you must look for. And whether the algorithm was trained on a single field or they had used multiple fields like IDX. They had used multiple fields. So though the algorithm is good, but if in India, when we use a single posterior pole image, it may not be that accurate in detecting diabetic retinopathy. So selecting algorithm depends on the circumstances of intended screening, where you want to screen, which is that you want to use a non-mydriatic camera, single field, multiple field, all these things play a role. Is the performance of an algorithm dependent on camera? So this was our work in Thailand, where we had multiple cameras across various districts. So 10 cameras, a variety of them, non-mydriatic, mydriatic. We compared the AI versus human grading. So you can see that once the image is gradable, the human grading showed so much variation, whereas AI grading, irrespective of which camera was used, was pretty accurate. However, if it's a non-gradable image, both human and AI, the performance was poor. So the lesson is that for gradable images, the performance of AI algorithms seems to be similar across the cameras. There are efforts to improve the efficiency of AI algorithms now, and this is one of our recent work where we tried, this is a work, again, multi-centric across globe, about 7 countries, data was pooled in, that if we label the OCT thicknesses to detect macular edema. So if you can see the second image, on the retinal photograph, you cannot see macular edema. But when this image was trained using the OCT data, because the patient has center involving DME, it can even detect that with a fairly good accuracy, the AUCs of nearly 0.9. These type of algorithms are the future, where DME detection would be in par with the OCT using a retinal image itself. This is another work which we have done with the Smart India study group, where we tried looking at the non-gradability. If we can detect whether an image would be gradable or non-gradable, with a very high accuracy, we could detect them. These are using non-mydriatic images. And why it is important, because if we can say that, okay, because the image is ungradable because of these features, we can ask the photographer to retake the image. There are a couple of implementation strategies which are there, how we can implement it in our practice. One way, Dr. Kim and group in Arvind have been using it as a fully automated mode, where they have kept these cameras at a physician clinic who have very poor knowledge of grading diabetic retinopathy. Images are uploaded and the AI tells whether to refer or not, or use it as an assistive mode, as we have been doing it in our hospital, placing these in interior segment specialists who have less knowledge about DR. They upload the image, they also grade diabetic retinopathy, and then the AI grading is shown to them, and they get a chance to augment their grading. This is a short video telling that how we have integrated it with our EMR. So the optometrists, when they do the workup, they take a consent and upload the retinal images also. Along with uploading the image, they also upload the other features, like whether the cataract is there, whether the pupil was dilated or undilated image was taken. So this is the optometrist part. Then he goes to a physician or a consultant ophthalmologist. He opens the image and he also has a chance to grade these images with the severity of DME and DR. He's shown the AI result now, and he has a chance to change it if required or use the same grading. So this is how we have been using at Shankar Nethralaya now, and this is the initial 350 patients. If you look the result, the AUCs are pretty similar to what we had shown in the JAMA paper. So in the real life, it works pretty well. This is regarding the referable diabetic retinopathy. The sensitivity specificities are pretty same what the initial development studies has shown. We also used another AI system which is developed in Korea to think of a different implementation mode. We use these images, and the images, the ground truth was grading by a retina specialist, and we kept it at a glaucoma clinic. And we saw that can we reduce the referrals from glaucoma clinic to a retina clinic, and we can see pretty good AUC of detecting diabetic retinopathy, referable diabetic retinopathy. So that means the mild and moderate cases could be managed at the glaucoma clinic itself. This is one of the case scenario of reducing the referral to a retina clinic. What is the acceptance level of AI among ophthalmologists? Many of you would have done this survey, which was given in the last lockdown, the APRAISE study done by Dr. Daniel Ting. Across 70 countries, more than 1,176 ophthalmologists tried looking at what is the acceptance and perception of AI. And you'll be soon seeing it in Lancet, a beautiful paper. And even we tried using machine learning to look into predict the acceptance of AI. And what we found, it's pretty good acceptance, especially in this COVID crisis. The willingness to adopt, people have been using mainly for diabetic retinopathy. Again, more preference to use it as an assistive tool. People are also trying to use it as a diagnostic or a clinical decision. And the common barrier is the medical liability. This is something which people are worried about. Thank you very much.
Thank you, Dr. Ajit.
Questions, I'll be happy to take.
Yeah. So we'll we'll discuss about this topic. So we'll move on to Dr. Ajit Babu for his talk. Dr. Ajit Babu, kindly share your screen. Yes.
So first, I wanted to thank Ajit Babu. As the president, he started this AIOS DR screening committee and appointed me as the chairman. Thank you very much. But anyhow, I hope this present committee will continue. And your Ajit Babu, you are still part of it. And with that, I think you should have, all of us should have this AIOS DR screening as our project. Thank you, Ajit.
So you are muted. You're muted. Dr. Ajit Babu, you're muted.
Ajit, you have to go back to the first slide. Ajit?
You're muted.
Ajit?
Please unmute.
Ajit, can you hear us?
Please unmute. Please unmute.
We can't hear you.
Yeah, you will.
Carry on.
No, Ajit, thank you for the president of AOS. You on all our requests, you started the AOS DR committee meeting, and we had the first meeting in
Chennai.
Yes.
And following that, we had lunch. Very nice lunch.
Yes.
Yeah. So I'm happy you started it, and you are still part of it, and we want you to be active, because I don't know why the Nayak and Maipal changed the thing. We have actually got it approved. It's not a presidential committee. It is approved by the general body. So
actually, we have formed a committee which is not under control of the president.
Correct. So tomorrow, I think we should point it out in the general body, and I request all the faculty here to be there and just inform them. I don't want to fight. Because already Nayak, I had a fight 2-3 weeks back. He's saying, no, you are removing the power of the president. I said, no, this is nothing to do with power. I said, Chairman Reforms Committee, I said, you take it over. I don't want to have it. But DR committee, I said, we want to do. I don't want whatever you want to give. But I said, the committee has to work continuously. Anyhow, so with that, I think all of us are aligned to that. And thanks to you, Ajit, for starting it, even in the VRF.
I would, at the outset, I would like to thank BNR Subudhi, my good friend, he is very much interested in community diabetic retinopathy screening, and which is very, very essential. And both the institutions, LV Prasad, SN and Arvind, they are doing great job in terms of the diabetic retinopathy care and community screening as well. Here I would be speaking about the WDF LV Prasad Institute initiated project actually. Okay. So if you see the density and prevalence of diabetic retinopathy, definitely India is in red, and we need to be very concerned about the same information. And within India, if you see the Tamil Nadu, Kerala, and Karnataka, Punjab are the most affected. And overall, among diabetic patients, diabetic retinopathy is prevalent around 35%, and PDR and DME or sight-threatening diabetic retinopathy is at 7 and 11% among 35%. What we have done is we have proposed a diabetic retinopathy project with WDF. This we have taken one district in the combined Andhra Pradesh at that time, but now it's in Andhra Pradesh. That is Prakasham district, which is having 3.2 million population, with 85% of the population is in rural with 56 mandals. So what we have done is we have done at the community level, we have screened for high risk determination, blood sugar testing of the high risk patients, and then awareness generation. And then once they are detected to have raised the blood sugar levels, then we send either to vision centers or to the physician, which is nearest possible. And we have identified at each level the nearest possible physician as well as vision centers that can be referred, these patients can attend. And we have provided the facility as well as at the primary centers where ophthalmic screening or retinal screening can be done, and treatment can also be done, and continuous medical education can be given. And the physician would be doing diabetic screening, comprehensive health checkup, and continuous medical education there also. But at the community level, the health workers, they will be following whether these patients are having a controlled blood sugar or deranged blood sugar. If the blood sugar is under control, then they will only report to the health workers that they are controlled or not. Because at village level, it's very easy to follow them by the health worker or a ASHA worker. If it is out of control, then only the ASHA worker or the health worker will refer to the physician nearest who is identified actually. So at community level, we have diabetic patient definitely will be there. Self-help group we have formed is among diabetics. We are all positive for diabetics. They formed a group and they will inform each other any problem which is arising, including the medicines. Because in AP, we have a facility for 108 and AIOC2021, which will provide the diabetic medication. So this information we have given to the patients so that whenever the visits, what time frame within the month, the AIOC2021 van comes and delivers the medicines, all these things are given. So we have licensed with the government health system, that is 104 services, and philanthropic organizations to provide some facilities to these people. And these are the instrumentation which we have given to the diabetologists, physicians, eye hospitals, and the vision guardian and field worker team. So if you see the structure of LV Prasad pyramid, community eye care is at the base where the field workers will be screening. And the primary eye center, it caters to 50,000 people, and secondary centers, only 3 are there in the district. And the screening methodology, what we have followed is either fundus photography or either direct or with the fundus camera. And health education we have given at different levels. Different part of the diabetic care delivery was done. It is like screening complications is only at secondary centers or tertiary care centers. It will not be done at a vision center. Vision center, the vision technician only screens for the retina, and if there are any lesions are there, then only they will refer to the ophthalmologist. Otherwise, this patient will go back to the community and they will come time to time. And this is again, if you see the high risk characters are done by the health workers, physicians, and diabetologists. From diabetologist, it will go to either nephrology, foot care specialist, or to the ophthalmologist, retina specialist. So ASHA workers and health workers at village level, regular follow-up of diabetics in the village by these people, and they will not refer unless blood sugars are deranged or there are any other symptoms of different systems. And the physician's opinion only will be taken if blood sugar is not under control. And they will screen for all other systems. And if the systems are deranged, then they will go to the specialist. And specialist phone number and location, address, everything is available at ASHA workers, health workers, as well as with the primary physician. So networking is properly done at the district level.
Yes.
And ophthalmic evaluation at village level is by vision technician. And any fundus lesions, then they will refer to ophthalmologist. If diabetic retinopathy changes are requiring treatment, then ophthalmologist will refer to retina specialist. So each thing is very clearly defined to them, and then they need to follow all this. And at each level, each documentation need to be done. So overall, diabetes mellitus requires a holistic approach rather than only ophthalmic view. So general physician and ophthalmologist is the primary level for diabetic retinopathy care. Retina specialist, diabetologist, food care specialist, nephrologist, and cardiologist. These were identified within the district. So they need not go out of the district to have the facility. So these 5 people will give all the care which is required. If at all, if it is very severe, then only they will be sending to a referral center. So cross referral between these 5 specialists is also facilitated, and time to time, if they are not doing, our staff will be doing all this. So the both diabetologist role as well as nephrologist role also was taken by the staff in terms of cross referrals. And this is what I was talking about, the registry of the diabetics in each village actually should be identified, and their address, name, address, phone number to be entered. And this need to be addressed, means added village by village, so that all our health workers who are going through the villages will update this registry, so that at the end of this the project, we will have the whole data of the whole district, so that we can have a district facility. And we have total, this is the load which is there across if you see 15.9 million DR is there, will be there. So India likely to have 1,000 medical retina practitioners by 2030. This is the calculation by membership of Vitreoretina Society. And 16,000 diabetic retinopathy patients per medical retina specialist. So that is a huge number. And 50,000 people of diabetic retinopathy patients per VR surgeon. That is also need to be considered. And 8 lakh people expected to have PDR. That is again a big load. 300 VR surgeons are there, and 1,500 advanced PDR patients per VR surgeon if distributed equally. But if it is not distributed equally, you may have to handle much more. If you see the urban population, as I mentioned before, 7.8% was there in the prevalence of diabetic diabetes, and 1.8 diabetic retinopathy. And this is in the clinic prevalence by reported by RIMA. Okay. Overall, I would like to say that indirect ophthalmoscopy with 20D or slit lamp examination and fundus photography for basic equipment that is required for screening. DM registry is required to maintain for each district. Networking of medical faculty to be identified, because it is not only ocular ophthalmic care, it is overall comprehensive care of diabetics as very, very essential. Health workers and ASHA workers are the basic bricks in screening and ensuring follow-up. So very essential for their involvement. Thank you for your kind attention.
Thank you. So thank you very much, Dr. Ajit. Now you can answer your screen.
Yeah,
so that I can finish up my talk before Dr. King comes for his talk. So thank you very much for the detail. Half of my job has already been done by you. So please unshare your screen.
Yeah, I'm doing that.
Yes, sir. Thank you. So now we move to my talk, challenges in the community. Challenges in the community. Am I visible? I'm sorry.
Yeah, you are not. Your screen is getting shared. You are not visible.
So now am I?
No, it says you started screen sharing, but we have yet to see the screen.
Double click. Double click.
No, it says screening is paused. It says.
You double click, it will start.
Otherwise, you stop it and then restart.
Am I now? It's okay.
No, the screen is yet to come.
Screen is yet to come. Yeah, it is there now, I think.
Is it? No, it's. Where is the screen?
No, it's not there.
It's okay now?
Yes.
Yeah, finally, at last.
Okay, thank you.
Make it full screen, sir.
Yes.
Yeah, it's full screen. You have to pinch now. You have to pinch and make it bigger.
Okay, so half of my job has already finished by Dr. Ajit Babu. I don't want to go into details. So these are a lot of challenges in the community in the TR screening. And it's a major public health problem in India. And diabetic retinopathy is an important cause of avoidable blindness. And up to 98% DR related visual impairment can be avoided by early screening and prompt management. That's most important. The early screening is very important. And the prevalence of diabetes already increasing from 77 million further, and more so during the COVID times. COVID is a number of cases. So, and COVID also is responsible for the inducing more amount of diabetes. Probably it has got some effect, some role. It attacks the beta cells of the pancreas. So number of diabetes will increase in the post-COVID era. So huge population or huge diabetic people to be screened. So Dr. Shashank Joshi, the popular endocrinologist from Mumbai, has already said that the number of diabetics in the poor is rising, and awareness is the casualty. Many people, they do not know that their diabetes can lead to complications. So this is another thing. At the 80% of people with the diabetes have uncontrolled blood sugar. That's the most important thing. This uncontrolled blood sugar may lead to complications. So what are the issues in the society, our community? There's a more rural population. 80% of our population live in the rural areas. And these people are mostly illiterate and they have low awareness of the health conditions. And again, another factor is the poor economy of them. And of course, the treatment is very expensive. Whatever you subsidize treatment is given by government even. So it is really expensive for these common people. And last but not least, the poor referral by our physician friends. So these are the challenges for the DR management, inadequate facilities in the rural areas. And more important so is the asymptomatic in the early phase. Unless the vision compromise occurs, the patient do not visit the doctor. Late presentation of ophthalmologist and available retina and eye space in the rural areas is very, very less, and lack of the good referral system. Doctors' issues, physicians, most of the times they do not know much about the complications of diabetic retinopathy leading to blindness, and they do not ensure in their patients for the periodic eye checkup for the blind, diabetic people, and they do not counsel the patients that they have to check their eyes. Today I've seen a patient of 15 years diabetic, and he's under the treatment of a diabetic doctor, but he has never referred. This patient came with advanced diabetic retinopathy in both eyes. So these are the challenges. So we have to create awareness among the physicians for proper referral, because the first sort, they are the patients, they see the diabetic patients. So what are the patient's issues? The most important patients is the uncontrolled diabetes. They do not bother about control of diabetes, and they lack of education, and they unaware that diabetes, if it remains for a long time, they lead to a lot of complications in the body. And of course, there's a poor infrastructure in the rural areas. Hardly there is a private health center or the doctor is available in the rural areas. And of course, the so-called health workers never visit them and do not advise that their eyes must be checked. Infrastructure issues, as I already told, there is a hardly that a hospital in the rural and the hilly areas, and secondary centers, hardly again 1 or 2 centers are there. District headquarters hospitals are still yet to be well equipped, and tertiary hospitals are very few. And of course, the common man, the financial crisis, and more so during this COVID era, they have to be, they become still pauper. So another important factor in excessive diabetic care is the distance. They have to travel long distance to check their eyes. And one single visit is not sufficient for them to get the eye treatment. So what measures to be taken? So we have to create awareness. That the most important that displaying banners, public meetings, distribution of leaflets, media, television, whatever the source of media available to us, we must create awareness that check your eyes, otherwise you will become blind. Screening by all the cameras already told by my friends. I don't want to go into details. And teleopticians, of course, next talk will have the teleopticians. An aggressive referral system by all the people who come in contact, first contact with the patient. The vision center, all the vision centers must be enriched with a mediatic, non-mediatic or mediatic fundus camera with the ophthalmic technician, optometrist, and he should do the screening and send the patient to the nearby hospital for the treatment. Secondary care center is to be increased, and all the secondary care centers should be provided with the minimum treatment for the laser and the anti-major treatments. Tertiary care centers, yes, we have to increase the tertiary care centers, but the VR surgery, advanced VR surgery will be available. So these are the measures if you take, then of course it can improve. So role of teleoptician, my next talk will be with the role of teleoptician. I don't want to go into details. So there are three societies, I would say, that community, workers, you can say. One is the AIOC task force, just about discussing Dr. Natarajan. Stop blindness, screening through teleophthalmic for the prevention of diabetic blindness, Jyot Jalao. Then, of course, IMA PDV, Dr. NSD Raju sitting. We are doing a lot of tremendous work in the last few years, and we have to create even society. Of course, our newly formed TOSI, if they all these join together, you must create a slogan in the society. Are you diabetic? Do you know that you will become blind? So if it goes in the mind of the patient, probably he'll come forward to further screening. So a joint effort by government, IMA, AIOS, TOSI, and NGOs like Lions Club, Rotary Club can all together work together to prevent diabetic blindness. So need to make diabetic care available, accessible, and affordable to the rural population. That is my message to all of us, so that we have to make sure that all rural people get the proper screening of diabetes. So thank you very much. So now I invite Dr. Kim to speak on the teleophthalmology. So Dr. Kim, sir.
Thank you, sir.
Yeah.
Can you
please say something about the teleophthalmology? Then we can discuss if time permits.
Are my slides seen, sir?
Yeah, very much.
Because yesterday I had some problem, that's why.
Okay, Kim.
Thank you. This is not a new topic. So this is something old which has been going on for quite some time. But unfortunately, in spite of driving this, we still see the general ophthalmologists, general physicians or endocrinologists or diabetologists not giving so much of importance to the screening for diabetic retinopathy. So most of the time, whatever we see, those patients that we see in our clinics or have already lost vision, and there's very little to do. So it's important that screening, there's no doubt, all of us have been talking about the importance of screening in the community before the patients actually lose their vision. So technology is one way we could do it, where what we call as opportunistic screening in all the places where the diabetic patients are seen by using telescreening. We've been doing this for almost since 2003 onwards, but still promoting this to the physicians has still been a challenge, and this continues to be a challenge. So because screening for diabetic retinopathy, it should be in the primary care physician's office, because they are the people who are seeing these people at risk of losing vision. And that's why we call it as an opportunistic screening when these patients are going for their routine diabetic checkup. Just like they get their blood investigations, they can get their eye examined as one in one place itself. So people who have good vision, even if you tell them to go to an ophthalmologist, they will not go because they say that their vision is good. So simple screening using the telescreening where the patient's fundus images are taken, transmitted to a reading grading center using internet. The retina specialist or the trained grader can grade these images, generate a report, and send it back to the physician's clinic. This is what we have been doing for the last almost 15, 16 years, where we have trained the diabetologist technician to take fundus photos, send it to the reading center. We generate a report. We developed our own software called Address, which helps in grading. It's a semi-automated software which helps in grading, and then a report is generated, sent back to the clinic, and this within a period of 1 to 2 hours the patient will get. Just like how he gives his blood and waits for his results, the eye report also comes. So by the time he goes to see the diabetologist, the eye report is also there. So based on the report, the diabetologist or the physician can refer the patient to the ophthalmologist as needed. This is another thing we have been doing in our Teni district, because our mobile vans would go to the primary health center where the diabetic patients usually come for once a week to collect their diabetic medicines. So we have had this thing, collaboration with the primary health center doctors, because they would not prescribe the medicine to the diabetic patients unless their eyes have been examined. So this becomes mandatory. This has not been possible in all the centers, but we have been trying in some of the PHCs where we have the government support to do this, so that every single diabetic who's coming to collect their medicines, their eye examination is done and the retinal status is measured. We also have multiple vision centers. We have about 91 of them, where these are primary eye care centers run by the optometrists, and they do the primary screening just like ophthalmologists would do complete eye examination. And one of them is doing a fundus photography. So recently we have incorporated in about 13 of our vision centers using AI, where the fundus photography once taken is automatically sent to the AI algorithm and the report is generated regarding the diabetic retinopathy status. But in all the other vision centers also, we continue to take the fundus photos, and then these photos are seen by the ophthalmologist in the base hospital, and based on the fundus data, they decide on further referrals. So with all these newer availabilities, earlier when we started, we had only those expensive Topcon cameras, but today we have a lot of these mydriatic and non-mydriatic fundus cameras handheld, and cost has become very, very cheap. There are a lot of development in using smartphones as a imaging device. So this is not a difficult thing. Anybody could do it. But the problem in this whole process has been finding the trained graders or retina specialists time to grade these images. And as Dr. Raji pointed out, there's a lot of inconsistency in grading. So AI plays a major role. With Google, Rajiv and myself have been working, and the Google algorithm displays within a short period of time, you get the patient's grading done. And this, we use it in all our vision centers in real time, and also in the diabetology clinics where we are doing this screening, where the AI tool has replaced the grader. And within a minute, the doctor or the diabetologist is able to get the report. And this encourages them to get it done for every diabetic patient who's visiting them. So in real time, we've deployed it in our diabetic screening, in our vision centers. As I mentioned, about 13 of our vision centers today use this in real time. Though we still are using in the back end, we're doing a lot of check or counter check with our manual grading where we are using AI. So the AI still seems to play a much better or much efficient in most of these situations. And so we've been encouraged to use it in many places. So with time, we will definitely see a lot of this being used, and it will definitely make a big impact if all diabetologists or physicians could screen the diabetic patients. This is just to show how telemedicine is in diabetic retinopathy. In spite of our country, which needs the maximum, we are still low in using telescreening for diabetic retinopathy. Well, in countries, Western countries like America, they use telescreening for diabetic retinopathy in much more efficient, much more better way. So it's essential to prevent this needle dryness. But I keep stressing that the onus of finding the diabetic retinopathy cases should not be just with ophthalmologists, but it should be with the primary care physicians, with the endocrinologists and diabetologists, who are the first point of contact for the diabetic patients. So this we tried with the PHFI in Tirunelveli district, but unfortunately, as long as we were running the PHCs, we were taking care of the process, it was running, but once handed over, there was no ownership to continue the process of identifying these patients in the primary health care centers. So, but this is the way to go unless it becomes a national policy to screen all the diabetic patients in the primary health centers or wherever these patients are seen. This will still remain a challenge for us in time to, for a long
Sorry
time.
to interrupt you, doctor.
Yes.
You can now
thank-
conclude the
Yeah,
session.
yeah. Thank you, thank you. So really, sir, Dr. Kim, I think the TOSI will lead the way. So TOSI having all stalwarts like you, Dr. Rajiv, Dr. Natarajan, I think it is so a way to do the screening in the future of all diabetics in our country. So thank you all for your nice talk in this today. And of course, we could have some 5 minutes discussion later, but somehow we could not get time to discuss because
But we don't have time. Yeah.
International speaker was that today.
But I think we did a little bit of discussion in between, you know, we did a little bit of discussion.
So
Okay,
nice to-
it was a very good program and thank you so much. And
Thank you,
Right.
doctors, for the wonderful session.
I thank Dr. Ajit Babu giving me this idea. So a long time back, we had discussed this program, I think last year. So thank you, Dr. Ajit Babu, guiding me for this program.
I think we are also lucky because we don't have to face an empty auditorium.
Yes.
Because it is
Bye-bye, sir. Good evening.
we will think that we have a full audience in the full auditorium.
Okay, thank you very
Okay.
much. So Dr. Baipal is here. Dr. Baipal, sir, good
Hi,
evening.
Maiparji.
Good evening. So
Everything has gone well. We did a very wonderful instruction course.
okay, thank you.
No, his lecture is good now during inauguration. That you need to congratulate him.
Yeah. He is always like that, you know. So every time you will have to congratulate him. Okay, then bye.
Okay,
You
okay,
were there for
bye.
the
See
full
you. Bye.
inauguration. It was very